Bismillahirrahmanirrahim. Assalamu alaikum, dear audience. Welcome to another session of our international teaching programs. And today our topic of discussion is about acute post-operative endophthalmitis. A very fine surgery, cataract surgery done, but the other day we find it out that this patient has developed acute post-operative endophthalmitis, a very serious condition, an emergency. So today we will discuss about its early diagnosis, how it can be diagnosed, and its earlier management to prevent further loss of vision. To discuss this very important topic of acute post-operative endophthalmitis, we have requested and invited our international speaker, Professor Kemal Ornik. Professor Kemal Ornik is a full professor and head of department of Ahi İvran University, Turkey. His career spans over 3 decades, and he has got almost 140 international publications to his credit. He's a teacher, mentor, a researcher. We are thankful to him that he has accepted our invitation to guide our audience about this very interesting and important topic.
Today I am going to talk about acute postoperative endophthalmitis. Postoperative endophthalmitis is a severe intraocular infection occurring after ocular surgery, mostly common after cataract surgery, as all we know. It both involves the vitreous cavity and aqueous humor of the eye. It's a vision-threatening condition, as we know, and it requires an emergent diagnosis and management. Incidence is really very, very low after cataract surgeries due to the advanced technologies in this area and the management methods. But we see the endophthalmitis more commonly after complicated surgeries, like vitreoretinal surgeries or penetrating keratoplastics. What are the risk factors for the endophthalmitis? One of them is wound leak. Leakage from the wound may be a risk factor for the infection. Another one is posterior capsular rupture. And another one is immunosuppression in the patient. What are the most common organisms we face in the endophthalmitis patients? First one is gram-positive cough. These are Staphylococcus epidermidis or Staphylococcus aureus. Mostly we see in the microbiology of the specimens. Another one is Streptococcus species, and rarely but severely present in one are gram-negative bacteria. The source is mostly the patient's own ocular surface flora. Main source, the primary source is mostly the ocular surface of the patient. And the other one is the surgical instruments we use during the operation. Bacterial entry through the surgical wound or the incision starts the infection in these eyes. And rapid bacterial proliferation in vitreous cavity goes on, and inflammatory response to these agents damage to ocular tissues. The onset is very rapid, mostly within 2 to 7 days postoperatively. We see symptoms mostly decreased vision, pain in the eye, redness, photophobia, and eyelid swelling, conjunctival chemosis, edema, corneal edema sometimes, hypopyon, vitritis, and reduced red reflex. But the most Common symptoms and signs are decreased vision, pain, and eyelid swelling. We must be very careful when we see these signs or symptoms after surgery, mostly in the first week after the surgery. How we diagnose the endophthalmitis? Surely this is an emergent condition. Therefore, we must diagnose the issue very, very urgent. Here, examination is the key point. When we see the symptoms and signs in a patient after the surgery, after a trauma, we must first think about endophthalmitis. We have some tests to support the diagnosis. One of them is vitreous or aqueous test for gram stain or culture. And if media opacity prevents fundus view, we use ultrasound. And there are some newly techniques like PCR and next generation sequencing besides these conventional techniques. Polymerase chain reaction, known as PCR, detects microbial DNA from intraocular samples. It detects pathogens even when they are in very, very small quantities and in a very, very short time, sometimes in hours. Next generation sequencing, this allows metagenomic analysis of the samples. It identifies both known or unknown bacteria, fungi, and viruses. Both these techniques are particularly valuable for culture-negative endophthalmitis. How we manage postoperative endophthalmitis? In endophthalmitis vitrectomy study protocol, firstly, we use intravitreal antibiotics like vancomycin plus ceftazidime. Vascular vitrectomy surgery is reserved when the vision is light perception only, according to the protocol. Also, we use fortified antibiotics, steroids, and cycloplegic mydriatics. Systemic antibiotics have a limited role, according to this protocol, maybe in highly risk patients or endogenous endophthalmitis. These may be useful for the patient. Another issue is immediate vitrectomy. Patients with light perception vision or worse, according to endophthalmitis vitrectomy study, may benefit from immediate vitrectomy. But nowadays we use in the operation room small gauge vitrectomy systems, and we may detect with molecular diagnostic techniques the highly virulent organisms. Therefore, when we balance the virulence of the organism with the patient's vision and speed of progression and risk of complications, maybe we can start with an immediate vitrectomy in the management of these patients. Visual outcome in these patients depends on the causative organism, initial presenting vision, time to treatment, and as we mentioned before, gram-negative infections have the worst prognosis in these eyes. How we can prevent these eyes to become infected? First of all, preoperative povidone iodine antisepsis is the key point. Very, very important. Lid hygiene in high-risk patients, of course. Limiting the operation room traffic. Use of intracameral antibiotics like cefuroxime, moxifloxacin. Proper wound construction and closure is very, very important after surgery. And of course, sterile surgical technique is also the key point to prevent the infection after surgery. Finally, we must know an endophthalmitis is an ophthalmic emergency all the time. Therefore, we must have a prompt diagnosis and management in these eyes. Prompt recognition plus intravitreal antibiotics is very, very essential in endophthalmitis. And of course, prevention is critical for reducing the incidence of this devastating complication of surgery in ophthalmology. Thank you very much. Hopefully.
Well, it was a very informative presentation, Prof. Especially this is a very serious and vision-threatening complication. So, how do you see the role of PCR and this next generation, what we call, Prof, this sequencing in the management of especially culture-negative endophthalmitis? How do you see its role?
Thank you, Alim. Culture-negative endophthalmitis is a common issue in ophthalmology, where patients present with severe inflammation, but no pathogen can be identified using standard techniques. In such cases, molecular methods like PCR or next-generation sequencing offer us very promising solutions. PCR detects, as I have mentioned in the slideshow, microbial samples. It detects pathogens even when they are in very, very small quantities and when they don't grow in the conventional cultural media. And it also can result even within hours. On the other side, next generation sequencing allows metagenomic analysis of ocular samples. Unlike PCR, it doesn't rely on predefined primers and can identify both known and unknown pathogens. Both of these techniques are very valuable, of course, for patients with culture-negative endophthalmitis. If current trends continue like this, PCR may be integrated into clinical practice within the next maybe 5 years as a standard diagnostic tool. Maybe larger use of next generation sequencing could be expected with the next 10 years also. But sure, they are very expensive diagnostic tools. Therefore, we need decreased costs and maybe with a more user-friendly technology for the ophthalmologists.
Right, Prof. Right, Prof, as you mentioned early vitrectomy study, this that doing less than PL positive vision, we should go for this vitrectomy. And as you discussed, now more and more surgeons don't wait to vision to go that low. They believe it is an abscess and it should be treated as early with vitrectomy with surgical approach. Do you think it is beneficial to go early vitrectomy, Prof? What is your experience about this?
You point an interest in the threshold for immediate vitrectomy. The endophthalmitis vitrectomy study established important guidelines that are being adapted into the clinic practice. This study indicated that patients with light perception vision or worse may benefit from immediate vitrectomy, particularly in cases of acute bacterial endophthalmitis. In such cases, early vitrectomy could help reduce the intraocular load of the pathogen, prevent further damage to the retina, and increase the chance of saving the eye. Considering these factors, there's an argument for reconsidering the threshold for immediate vitrectomy. With the advancement in small gauge vitrectomy systems and the ability to identify highly virulent organisms rapidly, maybe immediate vitrectomy in these cases of an aggressive endophthalmitis, of course, can be reconsidered. Of course, the focus should be the pathogen's virulence and the risk of rapid progression, not solely on vision level. For patients with better vision but at risk of rapidly worsening condition,
Yes, Prof.
early intervention with vitrectomy may prove outcomes and should prevent irreversible damage and preserve the vision in the long term.
Prof, about this intravitreal steroids, this is something controversial. There is infection. We can say it is an abscess-like situation, and giving these intravitreal steroids along with antibiotics. Uh, how do you see the use? In which cases, at which stage we can introduce this intravitreal? Is it safe?
As known, use of intravitreal steroids in these eyes remains a controversial issue. We know that steroids suppress inflammation and can prevent further retinal damage in certain eyes. In postoperative endophthalmitis, especially after cataract surgery, studies suggest that early intervention with steroids doesn't significantly worsen the outcomes and can improve visual outcomes by reducing inflammation and preventing tissue damage. Maybe chronic infections in these cases, intravitreal steroids can be used to manage chronic inflammation and prevent retinal damage. Besides, endophthalmitis caused by foreign bodies may benefit from intravitreal as steroids may be used to control inflammation around the foreign body, especially if the infection isn't rapidly progressive or if surgical removal is not immediately feasible. Therefore, the use of intravitreal steroids in endophthalmitis should be carefully considered, of course, based on the type of infection, the severity of inflammation, and the virulence of the pathogen. But their use is not recommended in cases of acute bacterial endophthalmitis and in cases of fungal infection,
Yes,
as known, without confirmation.
right.
The key point is that intravitreal steroids should be considered cautiously with an understanding of the pathogen involved and the time of the treatment.
Right, Prof. Right. Prof, this is a complication which almost every surgeon encounters in its life. And yeah, we can say this is inevitable. You do whatever precautions, it sometimes happen. And we know most of the time the patient's own flora, eyelid, these things, blepharitis, these things are contributing factors in acute post-operative endophthalmitis. And also we can say sometimes the things which we are using in our operation theaters, fluids, contamination, after surgery, post-op compliance of the patients, and all these things also matter. But Prof, as a surgeon, how can we prevent and minimize the rate of this endophthalmitis? Because after all, it is a sight-threatening condition.
You are also absolutely right. First of all, the patient's own flora, particularly from the conjunctiva and eyelids, is the most common source of pathogen causing postoperative endophthalmitis, particularly after cataract surgery and vitrectomy. Povidone iodine is the most evidence-based and effective antiseptic we use for ocular surgery, you know. It's broad spectrum, inexpensive, and widely available. Previous studies showed that 5% of it applied to the conjunctival sac significantly reduced bacterial colony count by up to 90% compared to now antisepsis or antibiotics only. Although ESCRS endophthalmitis study focused surely more on intracameral antibiotics, but it also confirmed the essential role of povidone iodine antisepsis as part of a prophylaxis strategy. Therefore, 5% of it applied to the conjunctival sac for 3 minutes prior to the surgery is the current standard. With 10%, we use for skin preparation. And besides this, we should care attention to the lid hygiene, particularly in high-risk patients. Scrubs plus warm compresses preoperatively, we may do this. Intracameral antibiotics were proven to reduce endophthalmitis fivefold. Preoperative topical antibiotics may be optional, maybe in high-risk patients, may be used. Another very important issue is eyelash isolation, face drapes, because they prevent lash or skin contamination. Also, we must reduce airborne contamination in our operation rooms by controlling the door openings, limiting the operating room traffic to reduce the airborne contamination. We must do them. And maybe additionally, we may say it for not for the surgeries, but intravitreal injections. Patients and surgeons should use masks during the injections, especially if they are talking. These are the main issues I can say for the preoperative prevention, Ali.
Very right, Prof. Very right. You mentioned about this because not only cataract or retina surgeries, we are having patients also after intravitreal injections because this is a routine and almost every clinic when these are given, patients are booked, long lists are there, and intravitreal bevacizumab and all these things are given. So sometimes they also develop infection because of these injections. So very rightly said, Prof. Well, Prof, it was a very comprehensive discussion, and you answered our questions quite patiently. And I strongly believe that this topic is very important, particularly for our postgraduate trainees, residents, our fellows, and also it will add a lot to the knowledge of our surgeons and refresh it that this is a very scary situation which develops and surgeons comes into anxiety and but it happens and it is prevent. We can do so much to prevent, but if it happens, it is timely decision and treatment. So, Prof, once again, thank you. You spared time for us to teach our audience. I know you are very busy, but whenever we request you, you are ready to teach and guide our audience. I'm thankful to you on the behalf of our audience, Prof.
It was a pleasure for me to be with you in another scientific talk, Alim. Thank you very much.
Thank you, Prof.
Hope to see
That's all I
you
said to
in
Prof.
the near future.
Thank you, Prof. Thank you.